All right, we're actually in chapter 43, guys. So, chapter, excuse me, 43, but we actually start on page 975. So that's chapter 43, and that is 975. Just pay close attention to the page numbers that I've given you, because there is a lot in chapter 43 that we actually don't cover. So just make sure that you look at this slide and you'll understand what it is that you need to review. Okay, so like I said, we're starting on page 975, and we're going to talk about ulcerative colitis and Crohn's disease. And these guys are categorized as inflammatory bowel diseases. They are, what you should know is that they are both autoimmune response. So if something has happened to the patient's immune system and specifically is attacking a specific part of the GI tract, you should know that they tend to run in families. So there's a potential genetic component. Like I said, it's autoimmune. There's factors for individuals who develop IBD, and this is to include lifestyle, to include alcohol consumption, the use of certain drugs, and certain diets. When we're talking about ulcerative colitis and Crohn's, then it's good to actually flip and go ahead and look at page 976. So like I said, this is an autoimmune disease. They both have periods of exacerbations and remissions, and there's no cure. But if you're looking at the table, 43:14, then what you'll realize is that there tends to be an early onset, usually in the teens to mid-30s, and then it tends to have a resurgence in the 6th decade of life. We're going to go down, you have your highlighter, and we're going to highlight the differences. And so, for instance, one difference is for ulcerative colitis, there can be a fever during an exacerbation. Weight loss is much more common in Crohn's disease, as is malabsorption and nutritional deficiencies. Rectal bleeding is more common in ulcerative colitis. And then when you move on down, it tells you about the location. So essentially what usually happens in ulcerative colitis is you have ulcerations that usually start in the rectum and work their way up the large intestine and involve the mucosa and submucosa lining. As compared to Crohn's, it can go or happen anywhere in the GI tract, all the way from the mouth to the anus. And it involves the entire thickness of the bowel. And then another difference that I would like you guys to see under complications, you'll see that fistulas, strictures, and anal abscesses are much more common in someone who has Crohn's disease. All right, in ulcerative colitis, again, this is someone who has ulcerations, and as you can see from the picture, that can start anywhere in the rectum up through the large intestine, involving the mucosa and submucosa. This person typically presents with bloody stools and abdominal pain. That's usually lower in nature. As far as multiple stools per day, it just depends on the severity of the disease. It could be what we call mild disease, and they only have maybe 3 or 4 stools per day that are bloody, up to 10 to 20 times a day bloody stools. And so it just depends on the severity of the disease. And so for ulcerative colitis, patients are much more likely to have bloody diarrhea and lower abdominal pain. In Crohn's disease, remember, this is a response that can affect all the way from the mouth down to the anus, but it most typically affects the small intestine. And so this person usually presents with persistent diarrhea, abdominal pain, and they could have multiple bloody stools a day, but actual rectal bleeding is more common with ulcerative colitis. what we tend to find with people who have Crohn's disease, because the small intestine's involved, they are more likely to lose weight and have malabsorption, because that's what would happen when the small intestine is involved. And again, people who have Crohn's disease are more likely to suffer from fistulas, strictures, and anal abscesses. All right, so we jumped a little bit. Now we're going to just go over the patho of colon cancer, which is on page 985. Okay, so 985. What do we know about colon cancer? We know that it's the third leading type of cancer, that it's more common in men than women, highest in African American population. Who's more likely to get colon cancer? Individuals who eat a diet that's high in the consumption of red meats or processed meats, someone who's obese, physically inactive, drinks too much, smokes, has low intake of fruit and vegetables. There is a genetic tendency. There's one particular type of disease called familial adenomatous polyposis. You don't have to know that, where someone is born with a genetic predisposition to have a lot of polyps, and these polyps do eventually turn cancerous. People who have IBD, we just talked about, have a higher incidence of colorectal cancer too. So what we know is that the majority, I think your book says like 85% of people who have colon cancer, colorectal cancer, have adenocarcinomas. And you can look, there's an excellent picture on page 986. And it shows you the different stages as a polyp. And that's how colon rectal cancer typically starts when it's primary, how a polyp grows, and how it eventually, if not found, will grow through the mucosa and actually gain access into the surrounding tissues, the lymph nodes, and other organs, and metastasize. And so we need to catch it early, because if it's caught early, very treatable. Unfortunately, early stages, there's usually very nonspecific types of signs and symptoms. Your book says maybe fatigue, weight loss, or none at all. And it's usually the advanced disease or cancer that's gotten out of the colon that causes the patient signs and symptoms. And those include abdominal tenderness, a palpable mass, an enlarged spleen, ascites. And so this is why it's so incredibly important that people are screened. And how do we screen? We screen everyone at age of 50 for the development of colorectal cancer. There's a couple of different types of tests, and you guys can see these on page 987. It talks about a flexible sigmoidoscopy. It talks about a barium enema. It talks about having a CAT scan. Also should be in there is a colonoscopy. Okay, and it says colonoscopy is the gold standard. Okay, and so the main thing is at the age of 50, if there's no family history of colorectal cancer, screening should begin. Now, if there is a positive family history of colorectal cancer, then screening will begin at an earlier age. I wanted to mention this is a colonoscopy, and this colonoscopy has actually identified a rather large adenoma, probably an adenocarcinoma tumor, and it's actually been tagged by blue dye. And so a lot of times colorectal cancers are found upon either having a sigmoidoscopy or a colonoscopy. Okay, so now we have skipped again, and we are on page 984, and we're going to talk about diverticular disease. And this is a great picture of a colonoscopy where a patient has diverticulosis, and you can see right here, and then just down through this patient's colonoscopy, there are a lot of diverticuli. And diverticuli are nothing more than outpouchings of the mucosa. This is a normal aging process. And most people have diverticular disease and they never have any issues with it. Okay? And so usually when someone has diverticulosis, they find it coincidentally on either a sigmoidoscopy or colonoscopy, and they're told you have diverticular disease. And they certainly have no signs and symptoms. Signs and symptoms would only occur if, one, these pouches would actually become infected, or two, that if these pouches actually eroded through the bowel wall. So that does not happen in the majority of people with diverticulosis. They have absolutely no signs or symptoms at all, and there are no special precautions that they need to take. We just say, hey, you want to go ahead and make sure you have a diet that's high in fiber, and that you want to eat lots of fruits and vegetables and cut out the red meats and the processed meats, and decrease your consumption of fat. And that high fiber diet will help to decrease the incidence of diverticular disease or the progression of diverticular disease. A lot of times people heard that you should avoid nuts and seeds, but your book reminds us that there is no evidence to support this. So we will not include that in our diet therapy. Now, diverticulitis happens to an individual who had diverticulosis, but now the diverticuli has actually gotten inflamed, and you can see this is a great picture of the inflammation. Someone who has diverticulitis a lot of times will show up with abdominal tenderness. They can show up with a fever, an increased white blood cell count, C-reactive protein, and then they have a diagnostic study, whether it be a sigmoidoscopy, a colonoscopy, or a CAT scan, and it outlines the fact that they have diverticulitis. And so why we get concerned with diverticulitis is because it can actually lead to pretty serious complications, to include perforation of the colon, an abscess formation, or a peritonitis. So typically when someone presents with diverticulitis, what we do is colon rest. So we just make them NPO, and most of the time start them on antibiotics, and the inflammation will subside. So it's just a matter of, with the colon rest and the antibiotics, can the antibiotics be oral antibiotics in a clear liquid diet, or is it possible that they're going to need to be hospitalized and actually put on IV antibiotics? Rarely is surgery required for someone who has diverticulitis, but it would only be if they had a complication, such as a perforation, or maybe they needed an abscess drained.